anterior is anterior longitudinal ligament. The one behind is posterior longitudinal ligament. The one between two spinal segments is interspinous ligament, and the one between the transverse process is the intertransverse process. And this structure, also called as ligamentum flavum, you can see on this side, the blue structure. Okay, this is this one, and this is green one is interspinal ligament. So all these structures are important for spinal stability. Now this is the again a supporting musculature of the spine. This is the most superficial layer. Only two major muscles, the trapezius and latissimus dorsi. इन दोनों के बीच की लेयर जिसमें आती है लेवेटस कैपिले, serratus posterior superior, rhomboids, serratus posterior inferior, and the deepest layer is the spinalis longissimus. These are all longitudinal muscles: spinalis longissimus, intercostalis, iliocostalis, spinalis thoracicus, longissimus thoracicus, in iliocostalis lumborum. So these are all named according to the structures they are attached. Now, what is a motion segment of a spine? Basically, if you just read about this structure, the structures in this structure, and how the motion is transmitted, you will know the entire structure of the spine. So this one segment is called a motion segment, which includes the spinal vertebral body above, the vertebral body below, posterior element, and the disc in between. Okay, so in this, important thing you can see here is when you extend, the vertebrae goes behind. Okay, posterior elements are compressed, whereas in the disc, the pressure goes from back to the front. Okay, because this is getting compressed, pressure goes in this direction. When you flex, the reverse happens, posterior elements expand, and the pressure goes from front to back. So you must have noticed, whoever has backache, when they flex forward, their backache increases. Why? Because the pressure gets transmitted behind. And what is that important structure behind? What is that important structure behind the vertebral body? The thing which is protecting spinal cord. So this pressure gets transmitted to spinal cord. What is spinal cord? Nerves. So nerves are getting compressed. So now coming to finally the spinal trauma. All the structures that we studied, if any injury happens to any of those structures, it is considered as spinal trauma. So it refers to insult to the spine resulting in damage to osteoligamentous complex associated with or without neurological component, which means if the spinal cord is still not damaged, even then it is considered as spinal trauma. Okay, so it will involve spinal column, bony injury, spinal cord, or both. So what is coming to spinal column? So for that, Dennis gave a 3-column classification. This is the whole structure. He divided this whole structure into 3 columns. This is 1, this is 2, and this is 3. So you need to know the structures in each column. So the front column, what does it include? Just by looking at this. The vertebral body, anterior longitudinal ligament, and intervertebral disc, but only the anterior 2/3 of it, not the whole. Okay, the posterior is considered a separate segment, which is the middle segment. Now what does that include? Posterior 1/3 vertebral body, posterior 1/3 intervertebral disc, and the posterior longitudinal ligament. And now the rest of the structures which are behind posterior longitudinal ligament at the posterior segment or posterior column, it includes what? Spinous process, transverse process, lamina, pedicle, which joins the posterior structures to the vertebral body, and the 3 ligaments: the interspinous ligament, the lamina, and the transverse ligament. Okay, so all the injuries which happen to the spinal trauma, when it happens, depending on which column is damaged or how many columns are damaged together, we decide the treatment, which is why this classification was given. Now this classification was made easier by AO, which divided these whole structures into just 2 columns. So in this, there was type A injury, type B injury, and type C injury. So type A injury is only the anterior column is damaged. So A1, A2, A3, you can see only the anterior vertebral body is damaged, and depending on, so everything in this two columns, everything which is in front of posterior longitudinal ligament is anterior column, everything which is behind posterior longitudinal ligament is posterior column. So A1, A2, A3, the vertebral body is damaged in various degrees. In B1 or B1, B2 or B3, both the columns are damaged, but different level. Means severity is different. And in C, C1, C2, C3, along with the injury, there is also translation or rotation. Okay. So C is basically B with translation or rotation. So only one column is damaged, anterior. Only both the columns are damaged. Both the columns are damaged. Plus there is rotation or translation. Okay. This is how we classify. Now we come to, so you can see here it is saying that these fractures tend to be stable. These fractures tend to be unstable, and these are again unstable. So what does stable and unstable mean? Of any injury, for any injury, what does stable or unstable mean? Stable unstable से क्या होता है? No, it's not recovery. Anything else? Anything else you can think of? What? Any guesses? What do they mean by stable? Looking at the picture, and what do they mean by unstable? आपस में बात करो, मेरे को ही बताओ थोड़ा. कोई guess ले लो. Like he said, recovery. Okay, leave it. So stable means even if that injury is there, but the person continues to function, the injury will not increase. Okay, the severity of the damage will not increase. Unstable means if the patient continues to function in these injuries, the injury will increase. The severity of the injury will increase. दे मेरे को. अरे अपना प्लान किसके का लिख देंगे. चल ठीक. Okay. So, okay, fine. So stable injury, the injury of the vertebral column will not displace under normal physiological load. In this, it will displace. Next, there are two types of traumas which can happen in spinal injury. One is primary, which is caused by the initial trauma, which means first the patient had the accident and there was a fracture. This is the primary trauma. Now, because of that fracture, further injuries happen to the spinal cord. That is secondary injury. So this is caused by initial trauma, varies from ligamentous strains to vertebral fractures and fracture dislocations, which all can happen in RTA. The spinal cord nerve roots, how does they get damaged during the accident or fall or whatever injury is there? They can get directly compressed. There can be physical disruption or damage to its blood supply. So all this will come in primary injury. Secondary will be because of the body's response to the initial trauma. So it can start within minutes, it can take or it can last up to months or weeks. Even it can happen also after weeks or months. So why does that happen? Because of the injury, the body responses, and the response is inflammation. So that inflammation will cause vascular changes, it will cause edema, and it will cause hypoxia. Now this will further damage the spinal cord. There will be ionic derangements because of the injury. There will be accumulation of neurotransmitters, production of molecules like arachidonic acid, prostaglandins, free radicals, and this is just basically an extension of existing neurological damage. So two types of injuries: stable injury, unstable injury, both the columns and three columns, and the anatomy. Till now, everything is clear? So what are the mechanisms of injury? How all can it get damaged? There are three basic mechanisms. Okay, so there are three basic mechanisms. One is traction, one is direct injury, and one is indirect injury. Okay. So what is traction? What is traction basically, or avulsion injury? How does avulsion happen? How does avulsion happen? Not just in spine, anywhere in the body. अभी किसी ऐसे हुआ पैर मुड़ के पैर में फ्रैक्चर हुआ कैसा हुआ है कौन सा फ्रैक्चर था हाँ तो वो क्यों हुआ था नहीं so what happens when your ankle twists there is a muscle attachment at that bone so that muscle attachment is stronger than the bone or the injury happens such a way that the force gets transferred through the muscle so muscle contracts strongly now instead of breaking of the muscle what happens it takes a piece of the bone where it gets attached so that is avulsion same way we have seen there are a lot of thick important ligaments in the spine connecting each other. So what happens because of that traction, the ligaments they don't get ruptured, they don't get damaged, they pull the bone fragment with them and cause the fracture. What is a direct injury? Usually suggested by the name, directly जो injury होती है spinal cord को, which can be through many ways. So if vertebral column instability in this direct injury is rare and direct neurological injury is more common. Then indirect injury we have already studied. Okay. So it can be forces applied, axial compression, patient jumps and all the force comes from ups to down, flexion distraction, patient bends forward or extends back, or it can be together flexion and distraction, which usually happens in RTA when the patient goes front and back quickly. It can be lateral compression, it can be rotation, it can be flexion rotation, shear, basically all combination of these forces, permutation combination. So spinal cord injuries in all these three cases can be direct trauma, compression, basically the primary and the secondary injuries we just read, or there can be disruption of the blood supply. This will be a secondary injury, this will be a primary injury, again a primary injury. So clinical features, what are the clinical features? Most common clinical feature will be patient will be asymptomatic. It can be mild pain, but most of the time they won't be complaining of pain in your back. Why? Because these are usually a part of polytrauma. Patient will have a major injury somewhere else and will be more concerned about that. So, if you want to diagnose spinal injury, whether it is existing or not, what is most important? What is most important? What? कैसे पता करेंगे किसी को स्पाइनल पेशेंट आया जिसने कंप्लेन नहीं करी स्पाइन इंजरी की या कोई बैक पेन की या किसी भी चीज की but you need to find out whether it has spinal injury or not. क्या चीज important है? Because you will see like 10 patients you saw in a day, 9 of them will be normal. So what will happen in the 10th patient? You will assume he is also normal. So to rule out a spinal injury, a high degree of suspicion is the first thing which you need to have. So if the patient is unconscious and a polytraumatized patient, you need to consider that they have an unstable spinal injury unless proven otherwise. High suspicion is the first thing. Then the first complaint will come, patient has pain. Or second complaint will come, patient has muscle spasm. Now when you actually examine the patient, or sometimes they can also complain the same thing, you will find out that they have either decreased or absent movement, either decreased or absent sensation. They can also complain of breathing difficulty. If you examine, they will have loss of reflexes. They will have loss of bowel and bladder control, which you need to ask the patient because they may not complain of it initially. And sometimes the patient also complains of sexual dysfunction, which usually is later realized, obviously. Okay, so these are the clinical features which you need, which the patient will tell and you will have to examine. So all these are basically related to injury of the spinal cord. Unless the spinal cord is damaged, all these things will not happen. So we come to management. How do you start management? Now that you suspect there is a spinal cord injury, what do you do? What do you do? Orthopedics. What? Investigation, yes. So in spinal cord injuries, there are three parts when it comes to management. First, there is a pre-hospital care, then there is a post-hospital, there is a hospital care, and then there is post-hospital care or rehabilitation. So first comes pre-hospital care, which is at the venue where the trauma has happened. What do we do there? What do we do there at the call where the trauma happened? ALS, BLS class हुई है? Has it been done or not? ATLS, BLS class ये सब नहीं हुई? Basic life support. Final year तक तो हो जाना चाहिए. Guys are in final year, third year. Okay. Shit. Okay, so this is pre-hospital, hospital rehabilitation. First thing is the pre-hospital care. The only goal is to prevent further damage. Okay. You're not supposed to treat the patient, just prevent further damage. Now this assessment happens according to BLS and ATLS, which I assume you guys have done. But anyway, so BLS is basically you have to take care of A, B, C, D, E. Okay, A, B, C, D, E. A is B is C is D is D pattern. D is what? C is D is momentum doesn't work. What? Those two. CNS. Okay, close enough. You check the deformity, which is neurological deficit. E is E is क्या मेडिकल का ABCD ही नहीं आता तुम लोग फाइनल ईयर में हो. E is exposure. You need to check, remove all the clothing and check for further injuries. Okay, you stabilize the spine. You can see the spinal board there. You can also see the cervical collars there, the head fixed, so it does not move anywhere. So all this is done even when the patient does not complain of any pain there. Why? Because there is a spinal injury until proven otherwise. Then you transport the patient and the patient comes to hospital. Now you come to hospital. Patient has come, you start a multidisciplinary approach, involve all the other departments. You resuscitate the patient if required. Clinical evaluation and including general examination. Clinical evaluation we just read, all the symptoms and signs. You do the spine examination, basically means a neurological examination of the patient. You do the other system examination, then send the patient for investigation only if the patient is hemodynamically stable. Okay, just because there is a spinal trauma does not mean you send the patient for investigation. The patient can die in the X-ray room or the CT scan room. Okay, so only if the patient is hemodynamically stable, you send for investigation, and once you have done everything, you go for the treatment. So all this happens in the hospital care. Once the treatment is all done, you send the patient for rehabilitation, which is the post-hospital care. Okay, so again, patient has reached the hospital. Maintain the high index of suspicion that there is a spine injury until proven otherwise. You ask the history, there is pain in neck or back. You check for neurological impairment. You look for signs of injury, which can be a hematoma or contusion, or it can be like this when there is head injury or cervical injury. Ask for bowel and bladder incontinence if the patient was able to pass stool or urine after the injury. Check for other injuries and previous surgeries for history, and then do the general examination. Okay, clear up till now? Moving forward, what is general examination? You have to rule out shock. There are three types of shock in this important: hemodynamic, neurogenic, and spinal. What is hemodynamic shock? Hemorrhagic shock. Loud. Shock because of blood loss. What is neurological shock? Neurogenic shock. What does that mean? How do you differentiate hypovolemic shock and neurogenic shock? Neurogenic shock happens because of what? Check. No idea. Sit down. Great. न्यूरोजेनिक शॉक नाम में क्या है? हाँ, so damage to nervous system. Sit down. Spinal shock means damage to spinal cord. Now, how do you differentiate hypovolemic shock and neurogenic shock, which is important? So, in both of these patients, there will be hypotension. Why is hypotension happening here? Because there is blood loss. Why is there is hypotension happening here? Because the nerves to the heart is damaged. So, heart is pumping slowly. How do you differentiate now these two? How do you differentiate? Okay, let's say body में hypertension हो गया, which basically means the heart is not pumping enough blood at once. At once, enough blood नहीं निकल रहा. Blood pressure normally 50 ml निकलता है, तो 30 ml निकल रहा है. So body will respond. So what will the body do in hemorrhagic shock? Basically per minute volume maintain रखना है. अगर एक बार में volume कम निकल रहा है, तो क्या करना होगा? Yes, the heart will start beating fast. Patient will have what? Tachycardia. Okay. To maintain the blood volume to the important organs. In neurogenic, what happens? What does the heart need to pump fast? Its blood supply, its intact nerve supply. Now even that is damaged. So what will happen? Bradycardia. Even though there is low volume pumping, heart will still be in bradycardia. Okay. So how does this bradycardia happen? So there are two nervous systems in our body, sympathetic and parasympathetic. What is the function of sympathetic? Which one is active all the time? Parasympathetic, yes. So function of parasympathetic is what? Reduce the heart rate. Okay. Function of sympathetic is what? Increase the heart rate. So how does that happen? How do they do that? So they do it like this. So this is sympathetic, this is parasympathetic. Both are acting on your blood vessels in the periphery. Okay. Now because of the damage, the sympathetic is damaged. So what happens? There is vasodilation. So because of vasodilation, because of parasympathetic. So all the blood gets pulled into periphery. So none of the blood goes back to the heart. So the heart has low volume to pump, and because the nerve system is not working, it pumps low blood to the body. So what is the treatment now? For hypovolemic shock, what is the treatment? What is the main problem in hypovolemic shock? Loss of blood. What is the treatment? Blood transfusion. Okay, fine. So imagine your body is a bucket. Okay, और एक नल उसके ऊपर चला गया जिसमें पानी भर रहा है. ठीक है, इवेंचुअली पानी ऊपर तक भर जाएगा. अब नीचे बकेट के एक छेद कर दिया जिसमें से पानी निकल रहा है. So that bucket का छेद is the trauma and the पानी जो निकल रहा है that is blood loss. अब इसमें मैं अगर ऊपर से पानी डालता रहूं तो कुछ इफेक्ट आएगा? नहीं आएगा. क्यों नहीं आएगा? क्योंकि ब्लड अभी भी लीक हो रहा है. So treatment is what? Stop that force. Okay, so first stop the source of blood loss, then start pumping blood. Okay, just because patient is in hypovolemic shock does not mean that giving blood will cure it, because the blood is still leaking out. So stop the source first, then once the patient has stabilized a little bit, then you start pumping blood. So that will be treatment of hypovolemic shock. What will the treatment for neurogenic? Will giving more blood help? No. So what do you need to do? What do you need to do? सोचो इसमें प्रॉब्लम क्या आ रही है? नहीं, हार्ट में क्या प्रॉब्लम आ रही है? हार्ट में क्या प्रॉब्लम आ रही है? ब्रैडीकार्डिया. तो क्या ट्रीटमेंट होगा? You cannot just activate sympathetic like that. What can you do? Something which starts with V. You cannot cause vasoconstriction. What you can do is increase the heart rate of blood of heart. Vasopressors. Call it vasopressors. What are the vasopressors? Yes, मूवी में देखा कि आप बेहोश हो जाते हैं इंजेक्शन लेते हैं सीधे छाती में ठोक देते हैं which is very wrong but it happens. So that is what adrenaline, noradrenaline. These are vasopressors. So that is the treatment. You give fluid and you give vasopressors for neurogenic shock. For this, you stop the blood and then supply blood. Now, what is spinal shock? It is physiological dysfunction following a structural injury. Okay, so just a physiological dysfunction, which means physically it is intact. Okay, only the function is disrupted for a short period of time. And what is that period of time? It rarely lasts more than 48 hours. So it recovers on its own. What does happen is below the level of injury, let's say injury happened at T12, so all the lumbars will be paralyzed. Okay. So all the lumbars, attendance attendance. So below the level of injury, there will be total paralysis, which means there will be no movement, muscles will be flaccid, and sensation is absent. And your bulbocavernous reflex will be absent. What is bulbocavernous reflex? Bulbocavernous reflex. हाँ. Bulbocavernous reflex. सुना है कभी? किसी ने नहीं सुना? अच्छा नहीं किसका? फिजियो पास करिए तुमने? बहुत ही कॉमन सा टॉपिक था उसमें bulbocavernous reflex. पूरा एक डायग्राम भी आता है ऐसे 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 करके. Sit down, sit. So there's a polysynaptic sacral reflex. It is the first to return after spinal shock. How do you do it? Compress the? Yes. So you either pinch the glans or the clitoris, and what happens? No. After you pinch, what happens? किसका? No, not urinary. Another exit. Yes. Loud? Yes. Okay. So once you pinch the glans venous or clitoris, or you touch the Foley's catheter, if it is catheterized, you check for anal sphincter contraction. That is your bulbocavernous reflex. Okay. So from one exit to another, that reflex, and it is a polysynaptic. You mean know what is polysynaptic? At least polysynaptic reflex मतलब पता है? नहीं? एक फिजियो क्लास में रखवानी पड़ेगी I think. यार कहाँ है? हाँ. So if the reflex is present, which is means bulbocavernous reflex is present, and there is still no movement and sensation, then you characterize as spinal cord injury. So basically, when the patient gets injured, up till the 48 hours, you cannot tell whether it is a spinal shock or it is a spinal cord injury. So you have to wait for 48 hours for spinal shock to recover. Only then you will know it is complete injury or just a spinal shock. So now you come to spinal examination. You check from occiput to coccyx for any deformity, parenting injury, hematoma, bruising, as we discussed before. And you check the spinous process. Okay, for tenderness, hematoma, gaps, steps. This is basically clear. How do you do the examination? How does this end? How does the spinal examination end? You do a digital rectal examination. After completing the log roll, check for anal tone, sensation, voluntary pinch, and document it. This is how you examine the spine. Check for any injury, check for tenderness, and check for digital rectal examination. And once you have examined, you characterize, you check for all these things, Okay, so C5, C6, C7, C8, C1, ये पता है सबको कौन सा मूवमेंट किसका होता है? C5 is C5 is पढ़ के तो बोल दो. Yes, elbow flexion also for deltoid. C6 is wrist extension. C7 is, so most of these functions, first comes the flexion, then comes the extension. So after elbow flexion comes wrist extension, then comes finger flexion, finger extension, finger flexion, finger abduction. This is T1. Then if you go to lower level, L1, L2, which is hip abduction. L3 is knee extension. L4 is actually ankle dorsiflexion. L5 is ankle plantar flexion. Sorry, L5 is toe extension. Yeah, great toe extension. And S1 is toe flexion or your plantar flexion. So it's flexion, extension, flexion, extension, flexion, extension. And then you also check for the reflexes. You can just read this from the book, nothing to explain. This is, leave it at your level. So once everything is done, patient is hemodynamic stable, you now send for investigations. CBC, RFT, LFT, chest X-ray, fast USG, fastest, ultrasound scan of abdomen. Then you check for diagnostic investigation, which is X-ray, CT scan, and MRI. MRI is emergency only in quad equina syndrome. What is quad equina syndrome? For that, you need to know what is quad equina. So what is quad equina? What is quad equina? Terminal part of spinal cord. What is the terminal part of spinal cord level? Till sacrum तो ठीक है, start कहाँ से होगा? At what level does the spinal cord end in adults or in children? Sit down. No idea. Okay, this is your idea. At what level does the spinal cord end? Does it go from all the way top to all the way bottom? No. So what level does it end? Yeah, loud. L1, L2 in adults, yes. In children? Yes. Or L2, L3 or L3, L4. It can go till there. So whatever is left after L1 and L2 is phylum terminal. Each fiber is called phylum terminal. Together they are called as quad equina. Why quad equina? Yes, they give a horse tail appearance. So because they are not protected by any layer of dura, protective layer, any injury to that, when it happens, the symptoms appear almost immediately. So that symptoms together they are called as quad equina syndrome, which is an emergency in spinal cord injuries. All the other you can wait for how long? 48 hours, we just discussed. Okay, so treatment wise, patient is in hospital, you start the definitive care. The first is always conservative management for all the stable injuries. What were the stable injuries? What were the stable injuries? A1, A2, A3. Meaning what? Anterior column is damaged and it does not progress. How do you do this conservative management? Can also be done for unstable injuries with no neurological deficit and patient who refuses surgical management, which is there for all every time. How do you do conservative management for spine? What is the conservative management for every injury? Immobilize, yes. And rest, immobilize. How do you immobilize spine? Just okay, fine. Cervical collar, okay. That takes care of cervical part. What about thoracic lumbar? Any collar for that? No. So what else is there? There is still a casting there, and there are braces. Okay, we'll come to that. So you give bed rest, you give traction, cervical collar, Minerva jacket, and thoracolumbar corsets. Okay, so these are the collars of thorax and lumbar. Cervical collar, Minerva jacket, and this is what? Where are these pins going? Going in the head. It's called halo traction. Okay, again you give for cervical injuries. You give traction, counter traction by the body weight and traction by those pins, and decompress the spinal cervical part. Okay, this is Minerva jacket. Those are thoracolumbar corsets. Okay, takes care of the thorax and the lumbar part. There are again lumbosacral corsets also available. Now come to operative parts. So unstable fractures with neurological deficits. Unstable fractures means they will बहुत ही important है भाई इसका कुछ high level business deal चल रही है. So unstable injuries means what? What say यार? अब यही पढ़ा है सच में. Loud. Again, I'm good. The severity will increase of the injury if the patient continues to function and put physiological load on it. So it can be with a neurological deficit, with progressive neurological deficit, or if the patient wants surgery and for treatment of the complications of spinal cord injury, which is this. So these are two rods. One is on the right side of the patient of the vertebral body, one on the left side of the vertebral body, and there are screws which are going. These are all screws which are going into the vertebral body, and those screws are connected by a rod. So this gives a support to the spine, like this. Okay. So these are the screws, pedicle screws. It goes in the vertebral body, and this is the rod. So what is it doing? It is supporting this vertebral body which is damaged in the spine. So the force or the weight goes from this vertebral body to this vertebral body directly without going on to this vertebral body. This is in the cervical part, that is again in the thoracic part, and that is in the lumbar part. Supportive care or the after the operation, what you need to do, take care of the skin, wash, powder, dry skin, to wash timely, no creases and gumbels, because all of this can cause, if not done properly, this can lead to bed sores. Why bed sores? Because the patient is lying supine for long hours, which you need to prevent. Take care of the bowel and bladder, which can be damaged if damaged. So intermittent aseptic bladder damage, all this you can read in your books. So thromboprophylaxis, which is very important, because when the patient is immobilized on bed for long period, it can have complications such as loud, deep vein thrombosis. Yes. Complications early, again DVT, pressure sores, UTI, bladder bowel dysfunction, neurogenic shock, pulmonary complications, which is also a complication of immobilizing on bed for long period. This is early complications. Late complications, if the patient physiotherapy is not done properly, they will develop contractures of the joint because they are not moved. Patient can develop chronic pain. Autonomic dysreflexia means what? Will have no control over bladder and bowel. Okay. Osteoporosis, and of course depression. Done. Now rehabilitation includes what? Should begin as early as possible. It includes basically physiotherapy to prevent the bed sores, to prevent DVT, prevent depression, prevent pulmonary complications, all those. Start movement as early as possible, but not too early. So, and all this is done. Along with that, you can also do psychotherapy if the patient are showing psychological symptoms. Done.